Hello everyone. Today I'm going to present this article about cognitive function of children with brain tumor in the treatment process. I think this article will be very useful for occupational therapy interventions. I found this article searching in the library database of your college using Boolean operators. I wanted to find an article that included occupational therapy and brain tumor and cognitive function and child or teen but not systematic review and no older than 10 years. The keywords of the authors are brain tumor, cognitive function, treatment process, treatment combinations, and occupational therapy. The purpose of the researchers is to assess the cognitive functions of children with brain tumor in the treatment process and the effects of different treatments on cognitive functionality. Although there is an increase of survival children with BT due to advances in treatment such as chemotherapy, radiation, and surgery, 40 to 100% of those survivors experience neurocognitive dysfunction affecting thinking, learning, and remembering, and causing permanent disorders in brain development. Current treatments in children with brain tumor support chemotherapy without radiation. The literature collected states that the white matter in children with brain tumor treated with radiotherapy is smaller than the volume of white matter in children with brain tumor treated without radiotherapy. Notice that although the neurocognitive late effects of chemotherapy alone are smaller than those of cranial radiation, they are still noteworthy in children with brain tumor. The side effects of surgical resection, according to this literature, are also significant in children with brain tumor. The design of this study is quasi-experimental because although there is a comparison between children with BT and typical development, or TD, it lacks randomization of the participants. There is also low internal validity because the researchers cannot conclude causality. The results of orientation in children with BT might be affected by the treatment or due to many hospitalizations, having the children lost or confused about orientation in place. The independent variable is the cancer treatment. This variable is not directly manipulated because the subjects are already part of one group based on their BT pre-existing characteristics. The dependent variable is cognitive function that will be affected according to the type of treatment administered to the children with BT. In the operational definition of this study, researchers understand by cognitive abilities, orientation, spatial perception, praxis, visual-motor construction, and thinking processes assessed using the dynamic occupational therapy assessment for children between 6 and 12 years old. The sample consists in two groups of participants, 102 children with brain tumor or BT and 90 children with typical development or TD in the control group, both from 6 to 12 years old. The group of BT was subdivided in 4 groups according to the treatment received. This post-test was used after they received the treatment between subjects in the BT group compared to the T group and between subjects dividing the BT group in 4 subgroups receiving different treatments that I will discuss later. The variables were investigated using visual histograms, probability plots, and the Kolmogorov-Smirnov-Shapiro wheel test that were used to analyze the methods to determine whether or not they are normally distributed using the SPSS software. Since the data, such as ages and cognitive function points, were not normally distributed, non-parametric tests were conducted to compare these parameters. The Mann-Whitney U-test was used to compare parameters between the two groups, children with BT and children with TD or typical development. The Kruskal-Wallis test was used to compare the cognitive scores of the 4 subgroups of BT according to the treatments they received: just chemotherapy treatment, chemotherapy and surgical treatment, chemotherapy and radiotherapy, and the last group receiving all the treatments. An overall 5% type 1 error level was used to infer statistical significance. I summarized all the children characteristics, the types of diagnosis, the treatments, and hospitalizations in this slide. Please notice that only 5 children with brain tumor received chemotherapy and radiotherapy treatment. Here are the tables discussed before about the characteristics of each group summarized in the previous slide. The 5 cognitive functions between children with brain tumor and typical development were assessed, and if you notice in figure 1, the total mean scores of the cognitive functions of children with BT were found significantly weaker than children with TD. And also comparing each cognitive area that was assessed individually, we can notice that children with BT were also found significantly weaker in every single cognitive area compared with children with typical development. As depicted in Table 3, when cognitive functions of children with brain tumor were examined according to the treatment and treatment combinations, it was found that all assessed areas showed statistically significant difference between the 4 subgroups. The children with chemotherapy treatment only had a mean of 116. Children with chemotherapy and surgery had a mean of 113.2. However, just 5 children receiving chemotherapy and radiotherapy, the mean is 89.2, and children receiving all the treatments, the mean is 87.7. This is a very significant difference in means when radiotherapy is used as a treatment. As depicted in Table 4, when making binary combinations comparing two subgroups, there are statistically significant differences found between children who received chemotherapy only and children who received all the treatments, and between children who received chemotherapy and heart surgery and children who received all the treatments. Group 1 received chemotherapy only and is significantly different in all cognitive functions compared to Group 4 that received all the treatments in orientation, praxis, and thinking operations. Group 2 received chemotherapy and surgical treatment, and compared with Group 4 is also significantly different in praxis, visual motor, construction, and thinking operations. This study gives occupational therapists and other healthcare professionals an idea of the weakening of cognitive functions of children with brain tumor, being those who receive radiotherapy the most affected in cognitive functions. There are several limitations in this study. Researchers think that missing or giving wrong answers to everyday life situations in terms of orientation in children with BT can be disrupted not only by the brain tumor but also by hospitalizations and treatments. More studies are necessary about how damaging a developing brain can affect spatial perception. Praxis, such as planning, organizing, and carrying out a sequence and doing what one needs or wants to do, should be addressed from both motor and cognitive aspects, as well as visual motor construction skills. The group of children who received radiotherapy was low. Only 5 children with brain tumor received radiotherapy. The conclusion of this study is bringing one more time the uniqueness of each individual, disease, and treatment. The occupational therapist must learn what type of treatment are receiving children with brain tumor in order to start a cognitive occupational therapy program to preserve children's cognitive functionality.